Welcome to Forecasting Impact, a podcast brought to you by the International Institute of Forecasters. This show brings together experts from academia and industry to discuss a wide range of subjects on forecasting science and practice in business, society, economy, healthcare, and education. Thank you for choosing to spend some time with us today.
Hello and welcome back to Forecasting Impact. I'm Laila Akhlaghi, one of your co-hosts today, and joining me for this conversation is my co-host, Professor Bahman Rostami-Tabar. Nice to see you, Bahman.
Hi, everybody. I'm delighted to be here, and thanks for inviting me to join this conversation.
I'm really happy to bring to you an engaging conversation because today we're traveling to Eastern Africa. We're going to explore healthcare product forecasting with two of our guests located in Kenya and Tanzania. Our first guest, Harrison Mariki, comes from Tanzania. He's the founder of Afya Intelligence, a community-based firm dedicated to transforming African healthcare through innovative data solutions and consulting services. Today, we'll discuss his recent work with over 7,000 primary healthcare facilities in Tanzania. Our second guest is Danielson Kennedy Onyango. Ken is a monitoring, learning, and evaluations professional who leads that domain at inSupply Health, a consulting firm based in Kenya. Ken is the regional manager of data transformation, intelligence, and impact, increasing efficiencies in forecasting and supply planning.
Nice to see you.
Harrison, I want to start off with you. You're a trained pharmacist. How did you get to where you are, and why did you decide to found Afya Intelligence?
Thanks, Laila. As you said, my background is pharmacy. I got to this journey when I started my internship at the National Hospital here in Tanzania, Muhimbili National Hospital, 2012. I learned very early on, being very enthusiastic to serve the clients, that you may want to solve the problem, you may have the know-how, but healthcare workers every day face that problem here in Africa, that they want to save more lives, but sometimes the products that they need are not there. So you find a mother coming to take ARVs maybe for herself and her child. And on that day, there is a stock out, and you tell them to come back a week later. It's not guaranteed that they'll come back. Those are the kind of challenges that I learned early on that we are facing my community. I was happy to join the supply chain space, working with the government and different partners over time to really try to solve that supply chain side. And over time, I have learned, having visited many facilities, to train them on the best ways to make sure that supply chain is improving. I learned early on that with data and innovation, we stand a better chance. And that's why I am in this space now with Afya Intelligence. So we are equipping healthcare workers with management tools that can help them to leverage the data that they have in forecasting and understanding the demand and make sure that the supply chain is improving. At the same time, making sure that the clients are able to get their medicine always and at the best price and quality. Thanks.
And we'll go into more of what Afya is doing in a bit. Ken, can you tell us a little bit more about your role?
I started off as a teacher of mathematics, and then I had the interest in statistics, so I've grown into statistics. And for me, I believe in data. Data needs to help us in making decisions. And having worked in the human resources for health, I've worked in the service delivery for HIV, I've worked in the health information systems. Prior to this role, I worked as a senior advisor with Palladium as a senior data use and M&U advisor that helped me to understand health information systems. And data is such a key thing. So I've had a passion for data. The role that I play at inSupply Health is basically trying to help the different communities, both in the public and private sectors, to really look at the health supply chain data so that they can be able to generate insights and make decisions. So we want to make better lives through continuous improvement. And one of the critical roles is on both demand planning and supply planning. And the work and the experience that we'd want to share is primarily looking at the forecasting bit. And we've had challenges, and with that, we've tried to be innovative, trying to solve the user's problems. One of the key things at inSupply Health is taking the approach of the human-centered design. So how do we empathize with the challenges of our users and try to provide them practical solutions? I lead the team that helps the different players in the health supply chain world to look at their data and be able to make critical decisions that can give better health outcomes. The primary goal is that we must save every life. We should not lose a life because of lack of our proper planning.
Harrison, Ken, you have both experience and you have worked many years on health product supply chains in Africa. Could you tell us a little bit about what is special about this and what makes such a supply chain different from other type of supply chains we see, like a commercial supply chain product, for instance?
One unique challenge, for instance, for here in Tanzania is that majority of the products that we are used, more than 90%, are imported. You really need to get your demand right because of the long lead times, and also the resources are very constrained. So we need also to make sure that you really understand the demand and able to get something that can help the government and all key stakeholders to be able to plan in advance. So you take, for instance, ARVs or family planning products. You have to forecast maybe like have a long horizon, maybe a year, 2 or 3 in advance, so that the planning can happen. If there are any framework contracts, can be entered, so that these products, when needed, they are available. So this is very unique to us. In addition to that, even the distribution that is done to the facilities is done on schedules. So a facilities maybe can order maybe once in a month, or sometimes even once in 3 months. So if the facility is not placing the right order to the medical stores to get their products, then the chance for them to get the products that they missed is again a big challenge, or expensive, because once the delivery vehicle moves from that facility, which is very far from where the central medical stores is, and then they raise maybe an emergency order for maybe 1 or 2 products, it's really logistic-wise, it's crazy to make sure that that product again go back to that facility. So those are some of the challenges that we are facing here with our public health supply chains.
Ken, do you have anything to add to that? Because I know you've done work in Kenya and then some work in Ethiopia and other regional countries. Is there anything you see that's different about the public health sector or the work that you're doing, those supply chains and private settings?
Yes, as Harrison has said, that in the sub-Saharan Africa, that we don't have local manufacturers for the health commodities. I think that is a key fundamental thing that just emphasizing. And majority of the people have access to health through the public health sector. So with the public health sector, there are different challenges. In some places like Kenya, there's devolution of health, which primarily decentralizes even the access to the health commodities. In Ethiopia, you'll find that the programs are put in different ways. So we have the vertical program commodities, and then we have the revolving fund, or in the essential medicines are primarily expected either to be purchased or be gotten through other means through user fees. So they are critical commodities that we consider as life-saving. So many times that you go wrong in your planning for them, it means their lives that are at risk. So you are risking to lose the life of a mother while delivering. You are losing a life of a child just because of a mere diarrhea, because you don't have, for example, zinc and ORS, and so forth. So we find that there is poor health seeking behavior. So many times by the time people get to the facilities, they are in critical stages. So you need not to let the health supply chain to be broken at any point. So with those many challenges, and even if you look at the many challenges around the human resources for health, even the data for making such decisions, sometimes it's rarely available, or if it's available in a form that it will take you time. So you need to really plan ahead of time. In sub-Saharan Africa, the health supply chain are special because they are limited resources. So you have to really plan well. Even when you have the resources, there are a lot of bureaucracies. So when you're planning for your lead time, there are many factors that you consider, and governments change, people change their minds. So you must plan really well. Demand planning is so critical in this case.
Both of you mentioned that you use data in a way. And then, Ken, you just mentioned that planning ahead is a critical factor here to make sure that health communities are in the place for people to come to facilities and actually use them. And sometimes is about saving lives of people, which is great. And here I bring in one tool that we believe that could help you to make such a planning ahead of time, which is forecasting. And this is where hopefully forecasting could be helpful in a way to help save lives, which is a great application of forecasting. So could you tell us a little bit about the like a typical practices you have in forecasting when it comes to the healthcare product supply chains?
So the practices are varied. so there are times that people just use their gut feeling to try and approximate what is required. And that is for many reasons. Sometimes people lack the tools, sometimes they lack the skills, and sometimes they lack the time. There is so much that is required to be done. And so when you ask me what is required, I just guess. The other ways that people use, they are what we call the semi-manual methods, where there are tools which have been developed like Excel tools to try and do a forecast of what is required. So whenever they're doing that, they can use a variety of available data. Most commonly used approach is using the consumption data. What was consumed in the last period of time, let's say period X, maybe in the last 1 year, the last 1 month, in the last 1 quarter. Then the other method that they can use, they can try to think about the services, the people who are seeking services. And lastly, they forecast based on the demographic or the mobility data that is available. So you find that the practices are varied. So they can use semi-automated tools, semi-manual tools like Excel to forecast, where they just draw a mere trend line and see what is happening. And in some cases, they are developed tools that are used to do the forecast that now follow on the time series principles of forecasting and so forth. But in the public sector, the most widely used tools is Excel based, using a simple trend analysis that can be used with aggregated data. There are issues around the quality of the data. They find ways of going about them. Lastly, we normally say that they apply an art. They will tell you that out of my experience, even if your Excel is telling me this, I believe this is what we need to do. So we normally make the comment that in the public health supply chain, forecasting is both an art and a science. Maybe I'd want to welcome Harrison if he has something to add.
Thanks, Ken. I think the methods that you mentioned also apply in Tanzania as well. And I think it will be the same across Africa. One thing that I can maybe add is that the forecasting can be done sometimes either at the facility level, where each individual facility focus for their own needs. This is an approach that currently is being done in Tanzania. And at times it's done at either subnational or national level. So that's also like another different types of focusing that happens. So in previously in Tanzania as well, we used to do forecasting at national level, but the government moved it to be done at facility level. And there are pros and cons to doing both. I'll give an example. Sometimes it's usually done at a higher level. This is maybe because also like issues around data quality. So you have to aggregate the data, and also maybe some of the errors will be eliminated at that level. But also the skills and the time for these healthcare workers to be able to do this at that level, where you find a facility where there's just maybe one healthcare worker. This also can be even like not a doctor or a pharmacist there. So not many facilities have pharmacists in Tanzania, and I think it's across the region. So Sometimes it's better to be done at national level. And if it's done at facility level, then really there is need for tools or assistance that is provided for these facilities to be able to do it accurately and also on time. Because when each facility has to do it, then you need good supervision, good training to make sure that all facilities are forecasting well. But also you have to make sure that all that data is aggregated in time, and you build in supervision levels, maybe at district and then at region level and at national level. So there are processes that in Tanzania for the what we call the bottom-up quantification, to bring someone else to review and provide feedback and improve the focus as they get aggregated to the national level. So what I mentioned usually is done for maybe using historical consumption data, but at national or subnational level, you could also use other methods as well, where you can look at demographics and services data, which can also help you to come up with a better focus.
And maybe Bahman, allow me just to add one small piece. The methods also depend on either the product or the program. So like in Kenya, there are what we call the vertical commodity programs. That is like the HIV, the immunization, the family planning, among others, malaria and so forth. So they like to do a central level at the national level. They do their forecasting, and then they disaggregate these downwards at facility level. And in Kenya, for the essential medicines, which is part of the devolved function, you find that now the forecasting happens at the subnational level. But even at the subnational level, it's aggregated. The data is collected at facility level, aggregated to subnational level, and then you forecast at the subnational level, and then you find a way of doing back and disaggregating it back to the facilities. Thank you.
So you've talked about some of the challenges, the quality of the data, the missing reports. Depending on the system, if you're aggregating, then you are required to disaggregate for distribution, or if you're disaggregating, you might have to aggregate, and then you lose the detail, you lose the specificity. The reason why we're having this call is both of you are trying to employ newer methods in improving the forecasting of these healthcare products. We'd like to hear about what those methods are. Are you using specific software? Can you talk about the mathematical methods that you're employing? How that work began? Where did it start from? Did you receive a grant for it? And who initiated the request to start these newer methods for forecasting? Harrison, I'll start with you.
So starting last year, we had a project in collaboration with Ken and the inSupply team. This project was funded by Paul McGovern Foundation. The aim was to see how we could leverage AI in improving the processes for forecasting. It's a project that's currently in its second phase. The first phase involved a lot of learning, using open source tools to develop tools that can support forecasting. So the question that we were asking ourselves, how might we leverage digital solution in AI to support this healthcare worker? And I'll say maybe in Tanzania we have 7,000 facilities. So how would you support these different facilities in different settings with different data of different data quality to be able to do forecasting? So that was one of the problems that we're trying to solve. So the tool that we're working on had to help first with the data quality. So helping the facilities to review their own data to see what gaps are there. At the same time, we had to develop a tool that could support the healthcare workers in cleaning their data, figuring out what are the outliers, what are the gaps, and then come up with statistical method that would help to fill up those gaps and cover for those outliers as well. At the same time now also find the best methods for models that could predict the needs for particular product in a particular facility. When we started using R. And I'm happy to see Bahman here, who also was able to come to Tanzania at one time and provide some training to staff here in Tanzania, including some of the staff that we we work with at Afya Intelligence. So we were leveraging R at that time to do the forecasting. And then what I can say within this process, knowing these challenges that are there in terms of data quality and the diversity, we make sure that the human is in the loop in the entire process. So we make sure that they see the data quality and they can acknowledge the issues. When we present the clean data also as well, we present it back to them to make sure that they can acknowledge and allow us to move to the next process, which is now at the forecasting part. They are also part of the process when we decide which model will be used for forecasting for products. So that's the work that we have been doing in Tanzania. Maybe I'll let Ken continue. Thank you.
Maybe I'll just add that we are collaborating with the Afya Intelligence through Harrison's team. We have a grant with the Gates Foundation that is requiring us to support the subnationals and the national teams to forecast, finance, and procure for health commodities. So we wanted to leverage how do we bring in efficiencies, because we've seen forecasting has been very expensive. It's an expensive affair. It takes days. People sit with the manual tools in workshops, sometimes an entire week preparing the data, doing the data cleaning, then come back again and another week. And this was one of our greatest challenge. It's becoming expensive. And as we know that resources are dwindling, it's not sustainable to go through that approach. What we did through the Patrick McGovern Foundation, we try to remove some of the inefficiencies in the traditional method that can help us to have better forecasts, which are more accurate and faster and more efficient, so that we can leverage on the resources. So what we did in Kenya, we started by first identifying the human in the loop. As you bring in technology, you ensure that your stakeholders, the users, do not fear the technology. There is a lot of buzz about AI. The first fear is how can we involve people who are non-techie to understand some of the things that we are using. So we say that we need to use open source tools. So we used R. Part of our baby steps was just to leverage when Bahman said that he's training people. There were stakeholders who were trained in the Ministry of Health. If you remember, we had to bring in some university students to offer support. People are not R savvy. So one of the things is just to prepare them. How do you prepare them so that you have the confidence? So to tell them we are using open source tools, you don't need to pay for anything. So that is bringing in their confidence. And the second thing is we mapped out the entire practice in forecasting. What are the current pain points and which areas are we able to leverage technology to either make it more efficient, to make it much faster? Then we ensured that the product that we're giving them, we created what we're calling a user interface that any person could use. So the user interface is one that a layman who cannot do coding in R should be able to interact with that particular user interface, like an R Shiny piece that they can just be able to log in and be able to access the results and even try to mimic the other processes. And lastly, we had to replicate what they are first doing so that they're able to have confidence and be able to identify the loopholes of whatever they're doing. So you're using it for an entire week. We can do this within less than 5 minutes, get you the same results, but these are your results. So with that, they were now confident. So that we're saying now we are proposing a new methodology, a new way of doing it, which is improving on what you're doing. So first, you are able to see that we can replicate. Sometimes we were even able to mimic the same process, give them the same results, identify the gaps that the data had, and try to walk them through how can you be able to improve that particular process. And with that, now they were able to have confidence. There is a challenge that not all of them may be able to grasp it, but you walk with them through. You get your champions to go through with you. So you'll find at the end of the day, you use a couple of models. You can use the linear regression model, you can use the ARIMA models, you can use the different methods, but you again have to work around the errors and be able to tell them that why are we choosing, what should we choose out of all these. So at the end of the day, you settle for one output which is agreed upon by the entire team.
Ken, it's great to see that you have used extensively, mainly both of you actually use open source in your work, and that's great to see. And also, it's great to see, you have invested a lot on improving your forecasting systems, from data to methods, but also to people, basically. Now, one important question here is, who are the users or consumers of this forecast that you produce in your systems? And then could you give us an example of how, they use the forecast that you created or you provided from your systems?
Maybe I can start and then Ken can add. So in Tanzania, as I had mentioned earlier on, the requirement is for each individual facility to do their own forecasts. So the consumer or the person who will be using the tool will start first with the health facility user, who would now have to go through the data cleaning, the data preparation, till they get their own forecast and then submit. So the second user now will be someone at the subnational level. This will be usually a district pharmacist, maybe supervising 20 up to 80 facilities sometimes. And this is also somewhere also like where we found digitization helps. So usually the subnational supervisors found it very difficult to review maybe a focus from one facility which would have maybe 100 up to 300 healthcare products within that focus that is submitted. So going through one by one and confirming just one facility would take hours, and now you have to do this for 20 or 80 facilities. So we make sure that they are also supported with the tools that we are developing to be able to review and not just aggregate the focus. So the same is with the other levels, which will be the regional level and national level. So I can say maybe this year one of our success actually has been with the review part. That's something that we believe we have been able to support well the ministry, being able to make sure that they're able to review all the facilities. So I think the focus that we are reviewed are worth more than 300 for this year. So you'll see how important this is for us to be able to provide the support that is needed for the facilities, the subnational level, and even the national level, so that they can get focus that they can use. So we'll continue to support them with that review process as well.
I think the main users, because we are working in the public health sector, is the different ministries of health at the different levels, and maybe with the different programs. So, for example, for the Kenya National Ministry of Health Family Planning Program, which is under the Reproductive Health Program, utilizes these for planning for the supply for family planning commodities. We have what we call the National Order Team that has got the different stakeholders, that is the partners and the national representatives, and use this for what is guiding the entire country in the demand for the next 3 years. So this data will be used by the other donors like USAID. They make their commitment, the Global Fund, and the other stakeholders, even the national government, in planning, because now they say that this is what we'll use for the next three years. The same time, it is used by the subnational, the counties. So the counties are using to plan for the needs for the essential medicines. They not just use it to plan for, they also use this to advocate for resources, because there is a huge funding gap. So whenever we finished the quantification process, they say, for example, Nairobi County, the need is 2.2 billion. Last year, how much were we allocated? I'm just using that as an example. Then they use these with even the decision makers. So the decision makers are not necessarily the health professionals, but they are, for example, the ministers, whom are sometimes drawn from either the technocrats or even the politicians, because the politicians make the decision for resource allocation. So the results, the findings are used to advocate for more resources. For a program like the maternal child health team, I've been using these to try to advocate for more resources. So the users are primarily, majority of them are non-tech people, they're the government officials, to make the different decisions at that particular level.
So you have actually talked about the data and data quality. So I was wondering whether you could elaborate a little bit more on that aspect of the system that you have, because based on my experience also working with the data from like different countries in Africa, the quality is an issue. But actually, the quality also could mean different, may have different definitions. But one aspect, for instance, could be, let's say stock out values, or sometimes just, missing values or incorrect, let's say, values in the data. So could you elaborate a little bit on the sort of issues that you have faced when you build your forecasting models?
I think I can start with that because that's something that we've been working here in Tanzania to try and resolve. I think this year, for instance, with the review module which we were working on with the inSupply team this year, after having hit a lot of issues with our forecasting last year because of the data quality, we decided also to support the review of the data as well and the review of the forecast. So what the tool is actually right now able to do is, for instance, there are priority items that for each health facility they are supposed to be reporting or forecasting for. So the tool is able to pick up any missed priority items within the data and then ask the users to make sure that they have included that data. So in the data preparation stage, we are able to pick up those missed items based on for instance, a dispensary may be supposed to have maybe at least these 120 products should be there. So if those are missed out, we make sure that they are picked out. Again, we try to compare what was used last year and what is forecasted this year to see if there is any major changes. So if there are any issues in terms of sudden changes, we are also able to recommend and say, okay, these are issues that we think you need to take care of before we move to the next stage. The other issue is around stock out. So even when we're reviewing the data, so we are able to pick out where we feel like this data may be not realistic. So, and that actually is one of the features that the tool is getting a lot of traction, being able to support, especially the supervisors at facility, for instance, the health facility in charge. They are very happy to see those results and work with their teams at the facility to make sure that the forecasts are accurate. Same with the supervisors at different levels like district, regional, national, to be able to see those issues. Again, picking up maybe those trends and saying, you know what, in your it seems like within the consumption data, it's saying these 20 items are the ones who are taking up most of your budget. Is this true? And we have figured out there something is really interesting that they will say, no, this is not possible. There's no way this product will be taking majority of my budget. Maybe I need to go back and make sure that the data is correct. So those are some of the issues that we are addressing. If data is missing, then we also suggest what that could be based on historical data. We look at seeing how we can fill those gaps where there is missing data as well using the technology that we are using. Thank you.
Just one thing, actually, if you step back, go one step back, sometimes the issue about the data could be its availability at the first place. Basically, is about having the right data, the data that you need to make your forecast and improve the decision that you want. So do you have the data available, or the data that you need really to solve your problem? So that's one question. Another question is now with the use of AI, and as we hear AI everywhere, and AI needs a lot of data. Do you think your own practices now over a couple of years, and then also now extensive use of at least the terminology of AI, do you think this helps to collect better data and more data that helps you to make better forecasts and inform the decision that you want?
So I'll try to answer that quickly and allow Ken to talk more about that. So in Tanzania, we have a system that are collecting some of this information. So for supply chain, we have the ELMIS, which is the open LMIS. That is every facility have using it for ordering their stock. So when they're ordering, we are always collecting information that is later on used in their forecast. So they send their orders maybe every month or every 2 months. And then that's the data that is aggregated over the year. And then when the time comes for forecasting, we are using that. So the quality, as I said, not always the best, but it's the data that we are using. But it's also why Afya Intelligence came in place around this time, because we saw at least there is that opportunity now to leverage the existing data. So the quality will never change unless someone starts to use it. So that's why we formed this company to support the ministry and the different players to use the available information. Same with the private sector. There are pharmacies are starting to use more POS systems, and also we have rolled out our own POS that we are supporting the private pharmacies to try also to make sure that we are getting enough information that can be used in our forecasting, as well as like building other areas like infrastructure. For instance, recently we won the Tech Hub Innovation Challenge, and some of the funds we have used to procure a server, a data analytics server that's now the ministry can use in terms of like strengthening the data use part as well. Over to you, Ken.
So thanks, as Bahman, as you've said it correctly. So data is an issue. First, is it available? Is it accessible? And of what quality? And at what time? So for the essential medicines in Kenya, we use the DHIS2 platform, powered what we're calling the Kenya Health Information System, or KHIS, and it is basically powered on the open source DHIS2. And health facilities are required to report on a monthly basis. So they're reporting their logistics data, whether the consumption, the days out of stock, potential expiries, among many other things. And the tool that we built was integrated within the DHIS2. So we have one user interface where you can automatically extract data from KHIS, identify the data quality issues that are there. So things like the outliers, be able to drill down up to the lowest level, but let the machine learning model to propose for you the alternative figures based on the quality of the data. So where data is available on KHIS or on the DHIS2, we were able to integrate and identify. There is a common joke that we say that one of the secrets of improving data quality is starting to use it. For example, if someone was to do for me a hairstyle which is based on data, and I provided one which is wrong, so that only one side of my head will be shaved and it looks funny, next time I will be keen to ensure that I provide it with the right data quality, so that I get the right style that I want for my hair shave. So that is the secret. So sometimes the decisions are painful. People are increasingly improving the quality of the data. But as inSupply, we are not just doing the forecasting. So you must approach this in different prongs. So there is a whole component of support that we provide the counties, which will look at the inventory management. There is a whole component that we talk about the data use culture within, which is routinely outside the issues around the forecasting, because forecasting is a time-based event. It's done at one point, but there is the culture that is consistently looking at. So we've developed, for example, what we call the indicator tracking tool that looks at different indicators. Number one, is the data available? If facilities have not reported, we talk about action-oriented dashboards. Who has not reported, so that one is able to identify, okay, you have the data, what's the quality of the data? And you are able to look at, you do triangulation either with the service data or within the data itself. Things like confirming the ending balance, and for the last month, is it the beginning balance of this particular month, and so forth. So this is something that we are routinely providing to the facilities and the subnational levels as a way of ensuring that they continuously improve their data quality. If you're just handling forecasting alone, it will be challenging. So you need to think about holistically, and we're talking about behavior change. So is it inculcated within the teams? That's why you'll hear, as inSupply, we talk about the impact approach. So the impact approach is just one of the ways to ensure that the data quality is continuously improved. Where data is absent, places for the essential medicines, there are times that data is not available in the national reporting systems. So what do we do? Again, with the national ministry, to come up with a way of doing sampling for facilities where you go and manually collect data. You use manual data collection so that you go and collect the actual data based on what is available on the bin cards. So you sample facilities, you group the facilities, similar facilities, so that at the end of the day, you will be able to forecast for facilities that you didn't sample for, because of, you look at the homogeneity of in terms of their characteristics, either with the workload that they have, the geographical location, and the disease patterns, so that you're able to classify them and now look at slight variations based on what we're calling the workload of the facility to do a generalization. So we've tried that particular approach and it's yielding. We are moving to a place whereby we are of course advocating for an ELMIS if it can be implemented. I think the government is positive about this. But for now, we are using the Sentinel sites to periodically collect data from the manual tools, but using digital tool so that we are able to integrate it in digital platforms.
Thanks, Ken. I'm going to come back to a topic that you were on a little bit earlier. You talked about the humans being in the loop in the review process, and then you talked about how you're making it easier for the decision makers that sometimes are not healthcare providers making the ultimate decision, asking for funding. And I'm wondering about the role of judgment in your forecasts that can either benefit or not benefit the accuracy of that forecast. So can you talk to me a little bit about that and the strength of the analytics versus the judgment, and where, how do you put the value or the amount or emphasis on which one's affecting the final outcome the most, especially since there's some funding associated with this?
Nice question, Laila. I would have loved to maybe do quantitative and go ahead with that. But unfortunately now, because of the context, so the quality of data that I think we have exhausted in this discussion today, but also like the changes that are happening every day within our healthcare space, new disease patterns, outbreaks. So sometimes we use both. So we use the objective methods, but also we use the subjective methods, which is what I think we are referring as judgment, to finally come up with the decision. That's why we allow the healthcare worker themselves to be part of the process always, despite doing all the calculations. We make sure the calculations are incorporating the assumptions that come from these experts, but also we give them an opportunity to make the judgment of which value to go with. I understand at the end of the day, it's forecasting, but you still have to do the other part of it for the quantification. You have to do the supply planning, you have to check the resources. So all those people in that pipeline would have their judgment on what is finally decided on what, for instance, approved by the ministry at the end within the budget. So what we are doing is providing the best focus for them to be able to make those decisions. As I said since the beginning, that the problem that we're trying to solve is like, I want to know what should I have in place so that I am able to save the clients and I don't have to write the out of stock that I used to write when I was a pharmacy intern. But also, what do I do so that I avoid wastage? Like if there's any avoidable wastage, how can we do that? So that's the problem we want. And for the patient, it's like making sure that they know that they can get these products from these facilities always, and they know that these products will be of quality and at the right cost as well. So to answer your question, judgment, I think, will always be incorporated, especially because of that process that it has to go, like, it's not just focusing, you have to do the entire quantification process where we have to get all these resources. And it's usually, especially in our context, it's not just the ministry paying for everything. Again, you have to find out what the gap is and bringing different stakeholders who can help to cover the gaps when needed. Thanks.
So maybe adding to what Harrison has said. So, and let me take you back just slightly when we are looking at the data quality. You remember you talked about, Bahman, you talked about the issues about stockouts. Sometimes there is non-reporting. So what we did is to ensure that we are able to have a user interface that walks the user to see and interrogate the data on their own, as a way of them having confidence and faith that this is what we normally do, this is what the machine does, and they have the confidence. So we have adjustments for stockouts. So the human judgment sometimes happen. You are seeing a trend and there's a downward trend and it is consistent, and sometimes machine may think that it's going down, and the human judgment, they will tell you, okay, in this particular case, we know we started having a national stockout. And because of this national stockout, it's not that the consumption was going down, it's because we had a prolonged stockout. And because of that, people are reporting consumption, but it is a consumption which is based on this. So even before looking at the stockout data, the days out of stock, it explains itself. Or there is, let me add the other part, there is no stockout, but there's a downward trend because they are strike. The healthcare workers have gone on strike. So the same people, because you're looking at public health data, the people are still seeking help, but now maybe in the private facilities, and this data is not coming. So they are able to tell you that in this particular case, there is no stockout which is being reported here, but we know the healthcare workers, the nurses were on strike for this period of time in this particular subnational unit, or it was a national strike, and hence people are able to make judgments. Going back to the family planning program, so even when we use the AI and machine learning method, they did not adapt all our outputs. We have 13 family planning outputs, which you're supposed to use 3 methods. So there is the human judgment that comes, and we'll say now, you've used the AI in everything that you've done, you've gotten the output based on service data for the forecast, you've used the consumption method, but on this one, we are using the demographic because we know these. They can be saying that we know, let me use DMPA, SC, and IM. We know for sure that the national program.
Those are injectable contraceptives, just for the folks who don't know. Yeah.
Thank
Okay.
you. They will make up like a decision and say that we know for a fact that in as much as there is an upward trend, we are making a deliberate national decision that we want to scale up the usage of this as opposed to this. We are making a strategic decision. So in as much as the focus is telling us this is the right way using either consumption method or the service method, we would want to use a different way. We are overruling this, and for this we are settling on a different method. So last year in November, December, when we were doing the forecast, out of the 13 commodities, 9 out of 13 why they used our method. But for the remaining 4, they opted either to use demographic method and some judgment. They are saying that no, we have a national scale-up plan, and because of the national scale-up plan that we have, we are overriding these. Maybe someone would say that we should be able to incorporate some of these in the method that we're using. That's futuristic. At the moment, we were not doing that. We were just learning the data and being able to do that. So there is judgment. There is the expert judgment. They are able to say, is the treatment protocol being used? We are saying that when someone comes to the facility, this is what you should be able to give them. But in the reality is, out of our expert opinion, we know that this is not being adhered to, and hence we are advising this. So remember, initially I talked about the art and the science. So you start with the art, with the science, but the ultimate decision is normally they go and end up doing an art combined with the science and come up with what they believe is the best outcome.
This is fascinating, Ken, and I think actually this is something as an important principle that we also discuss in forecasting, which is relying on domain knowledge, which is fundamental when you build models and use forecasting. And I hope that the sort of thing that you discuss, you somehow record them somewhere in your system, and you can go back to them at some point and see how fundamental those factors were really when you discussed them at that point in time in the past. And then if they are something like that, it is maybe the point where you have to decide to build them in your model, as you say, at some point. But I think it is great, and I think it is important maybe to record them in your system, and hopefully you can go back to them to see how effective basically they were. Now, let me just go back to a point about the judgment itself. I think based on what you have discussed so far, my understanding is almost all the decisions that you're relying on forecasts are manual. So there is no automatic decision basically that use the forecast and the decision is made automatically, like ordering. So almost all of it is manual. And then frankly, as a decision maker, I want to make a decision with or without the forecast. And also, I'm not really interested in a best forecast, but in a best decision, really. So that's what I care about, is a good decision that I want to make, with or without the forecast. So I'm wondering, when it comes to developing, your solutions and the forecasting model, what sort of metrics you use to judge the effectiveness of this solution? Because you could actually just go and calculate an error metric based on the forecast property itself, or you could go and look at the bottom lines like saving cost, reducing stockouts, and so on. So could you elaborate a little bit on the sort of practices you have when it comes to the effectiveness of these solutions and how you judge that?
Yeah, thanks. Yeah, so I think those are the best metrics to use at the moment, even not accuracy. Especially because, for instance, where we are, the innovations that we are talking about here are still early on. Like we are still improving on the process, the tools themselves. So what we are seeing in terms of impact on what we are doing now, so it's really improving, for instance, the process. You get this feedback from the users, like, where has this been before? Like, why didn't we have this maybe a year ago when I was reviewing my order? Could this have been there instead of now when I have all my data? Could it have come a little bit earlier when I was filling that data? Maybe I wouldn't have filled the wrong thing. So we are seeing that impact, and we are seeing those improvements. So something that we are tracking, for instance, in the tool is like, we are tracking active users who are using the tool, and we can see, okay, so this means that they are using this. We are tracking the value of commodities that are being analyzed in the process, and maybe over time we'll be able to see how that either increases or decreases based on the decision that people are making. We are also seeing like improvement in the process itself. So the workshops that Ken also spoke about, the forecasting workshops, which will usually take weeks, but within that week you'll find either we are able to save time or improve what is happening within the workshops. You may find people, like you have 10 people maybe in that workshop, but sometimes it's just 2 people who are doing most of the calculations on Excel, because they are the Excel masters. But what the tools that we are developing are empowering all the users to participate in that process, and in turn, it's improving the value or the quality of the forecasts that are generated. So those are some of the impacts that we are seeing. Something else that we are helping is like translating the way people have been looking at the data. So instead of just looking at numbers, like number of tablets and all, and so we're able to help them to look at in terms of how valuable that is, in terms of like transforming that into cash, so not understanding what the inventory costs are, but also translating that into what that translates into service. So that is really important when they go to the next stage of social attracting resources to support the forecasts that are generated from that process. Yeah.
Maybe I can summarize on the other piece, and we agree it's not entirely that people are using the, the manual methods, but I can see that we are seeing a scenario whereby confidence, people are increasingly having confidence in the automated results. One of the things, the metrics that we used last time that made the change from 2 to 9, adopting using 2, or only, I think the initially either used just 4, but when we calculated forecast accuracy, there is, in the scenario where there was no national stockout, everything was going on okay, and they looked at, if we used this particular method, which one gave us the best, so that we were not going to either be stocked out or have excess and contribute to expiries. So we see that they realize that the areas where the commodities that they chose to use the AI, for example, our tool, we realized that the accuracy levels were higher in those particular places. So this time they had more confidence. The second thing that has really helped is people were saying that we come to this meeting, we are stressed doing this Excel, like this is not what I was trained for. I'm a trained medical doctor. This is not my work. So just the realization that they can do a few clicks and get the outputs, which through the longer time of comparing the manual method and this one, they have the confidence. They say, why do we need to waste all this time? I remember someone say, Ken, just bring your tool, give us the results so that we concentrate in making maybe more decisions on the supply planning as opposed to taking time crunching numbers. So they see like time saved in doing the entire process. To the donors, it's so happy that they can say that. I remember when over the holiday, the Ministry of Health asked, share with me that particular, again, the link, I've missed it. so that I know what is happening. They know that I don't need to call people for a workshop to do this thing. I can have something that I can do quick decisions and maybe just call people to validate and we finalize. So there is a lot of value addition that is making and compelling the people to adapt the tools as opposed to still relying on the manual methods. Increasingly, I have faith that there will be reduction in the manual methods and people can close their eyes and say, let's click and use the tool to give us the next year's forecast.
Thanks, Ken. I want to know if you have anything to pass on to other folks who might be thinking about replicating something like this. What kind of resources have you needed to create the system in terms of funding, human resources, the skills, the approvals, perhaps? And do you think that this is something that's easily transferable? What parts of it are, maybe not? And then what else in addition would you need to do even more?
I think quickly I would say what I think has been good or has worked well has been the partnerships. So partnership with inSupply Health, partnership with the Ministry of Health in Tanzania. I think that that has been the strong point for us to be able to do this. So we have been learning together over time, and there's been a lot of ownership from the ministry side. And that has really helped us to succeed to the level that we are, to a point where we can see where we collectively want to go and want to continue to work together to make sure that we achieve what we want, which is making sure that the service is not interrupted because of lack of products. And in terms of this being transferable, yes, this is very transferable to other areas, other countries. And in Tanzania, for instance, what we're trying to do is transfer what we have learned from the public sector to the private sector as well. So we want to make sure that we can work with the private sector, so build up those relationship with the local pharmacies, distributors, to be able, again, to leverage data that is there to help them with AI-powered business management tools that can help them save more clients, but also reduce the margin. So, because for us, what we see in the private sector is like the inefficiencies that are coming without knowing the demand. What they end up is making the customer is paying for that in terms of cost. Like the medicine is, the margins are high, and also they're trying to cover the wastage that they go through when there's no demand, but also other issues around the logistics to make sure that those products are there. So we think by impacting the forecasting in the private sector as well, we'll be able again to try and lower the cost of products in the private sector for the clients as well.
Thanks, Harrison. Ken, in addition to those relationships that Harrison talked about, what other resources did you require?
Yeah, so I want to mention one thing that may be contributing to that. We know that there are people who have tried to do what we're doing in the public health sector and have failed. So trust is a fundamental thing. And how do you build the trust? For example, people will say, what you see when people hear of AI, who is getting my data, who is having access? So, for example, in our case, even when we integrated with DHIS2, you can't have access to that data unless you have access to DHIS2. So we built in so that we have the logging in. You have to get authentication from the DHIS2 for you to have access to that data. So just building trust is quite a key thing. Investing in everything wholesomely, so that it's not just at the forecasting stage. You must invest in where the data is coming from, or partner with others who are working in those particular areas. Because at the end of the day, it boils down, do we have products to save lives when they are needed? So we are currently exploring things like prioritization. You forecasted that I need this quantity, but I have less resources. What do I prioritize? So we are trying to integrate, for example, such tools to ensure that that is taking place. The other thing that I'll say, that because of the challenges that we've had, and it's something that maybe people can think about, is digitizing, so that data is available. So you need to ensure that at the lowest level, people are able to have simple tools that the data can be easily accessed. Have more people who have interest. It is you doing and you giving them results. They will not trust you at the end of the day. So how do you bring the people in the public sector so that they can also feel that they are confident with the technology that you're using and they are on the driver's seat? So we think about scale, from the beginning.
Okay, great. Well, looking ahead, what do you see as the future of forecasting in healthcare sector in Africa in particular? All of us, we know that now foundation models like ChatGPT, they are used massively across different sectors. And forecasting is not an exception as well. You know, we have several models like Time GPT, Times FM, and like Llama models. They are developed for forecasting, and these are foundation model for time series forecasting. Do you think that these are the sort of models that you could also use, especially if they use less skilled actually people in analytics and let's say forecasting?
Definitely, those are things that should explore in the future. So the challenges might be making sure that we have the right infrastructure and also the skills within the region. Given that, for instance, with healthcare, there is prioritization by ministries to make sure that most of this data is processed in country, making sure that, again, we have good frameworks that allow for these innovations to take place. That is very important. But definitely, we have been looking into that space, and we know there are opportunities in the future. But some things have to be in place. So those building blocks have to be in place as well.
Yeah, and for me, I think I'll just say that when you solve real problems, whatever solution you give people, they will use it. Maybe in the course of the day, you'll find yourself going to ChatGPT and any other tool. It's because it's solving your real problem. So someone, a decision maker, at one point does not care, doesn't want to be stressed. They just want to know, what do I need for next year for my planning? So if the solution is in a language model that they just type and they get the results and they have confidence in the results, that is the way to go. Because decision makers don't want to hear stories. They don't have the time. They want to hear cost savings. So if that is the opportunity that is available, that is where everyone is longing to go to. The downside part of it that people are questioning themselves is on that by doing this, are we impacting on the environment? So if there is, so what are the measures that we are taking? Is it costly? Because if it costs so much to do that same thing, then no one will be willing to invest. I'll tell you, in the public health sector, cost is a factor. So in as much as we must balance between the technology that is available and the cost, and who is taking up that cost. Because we're talking about sustainability. So we must have the transparency in terms of the cost, transparency in terms of what is going on in the future, because there's also the fear, you'll make me so addicted to using these, then when I now want to use it, you start telling me to pay for it, and I'm unable to pay for it. So the ministries of health are actually very cautious on what you are introducing to them, especially at the point when you're saying that it is free. So be part of the process, work with them, feel their challenges, and offer solutions with their challenges, and you'll not strain. Thank you.
I love this, Ken. I think this is really great. So basically solving real problem, a problem that someone really cares about, not necessarily a problem that AI has a solution for, which is not really my problem. So that's a great answer. Yeah, thank you.
Yeah, thank you, Ken. I'm going to quote you.
Thank you.
We've reached the end of our conversation, but I'm wondering if there's anything that we didn't ask you about that you think is important for us to know.
Can you want to go first?
You've given me the opportunity. So I think the only last thing that I'm talking about is, I'll still go back to the trust issue. That one of the reasons why we've been really successful is that believing in the local talent. That localization is one great thing. That part of the work, for example, inSupply partnering with Afya Intelligence in Tanzania to do some of the solution that we're doing, is because Harrison is viewed as a local. He is able to speak the language that they're speaking. He can switch to their Swahili very comfortably and be able to tell them and develop that particular trust. There is talent in the sub-Saharan Africa. They just need to get where to maybe partner with the right people to build their skills, to continue building the skills. And with that particular trust, the solutions will be more compelling, they are more scalable, in those particular contexts. So for me, I have faith that there is rich talent. It's great to see that we are saying some of these things without mentioning the companies, but I know I'll say again, there are people who have tried this. They were not trusted. They were not seen as locals, and they could not even get that data. Data access is key. I can't give you access to data if I don't trust you and I don't know what you're going to do with it. So there are many myths around AI and what you're going to do with my data. So for you to build trust, work with the local, and let's keep on exploring. Thank you.
Thanks, Ken.
Yeah,
Harrison, anything to add?
not much. So I think for me, it's just a testament to what Ken is saying. So Afya Intelligence is a company of very young guys from East Africa who are just passionate about making sure that access is there. And when we started, there's a lot that we are learning in the process, and we are welcoming partners. We are welcoming partnership with experienced companies to continue to challenge this problem. We have not locked ourselves in. We know it's localization, as Ken has said it, but also we are opening to partnerships. As I said, it's a partnership problem, like for us to be able to solve this, and we look forward to doing this more and make sure that we have improved the availability of products in Tanzania. But again, when we started, our vision is to go regional. So more partnership was again to move this to other countries as well. Thank you.
Thank you. And Lele, sorry for coming back. I know time is fast spent. Let me just say one last word. And the last word is on co-creation. That the solutions need to be co-created with the people, and to further build on what we said about their problem. You cannot know their problem if you don't adapt human-centered design. Like as inSupply Health, we believe in the human-centered design approach as part of designing our solutions and co-creating with the users. And this is a testament of trying to bring in something that is believed to be complicated, but working through with our stakeholders to build trust so that we can give them a solution that they have confidence in and they can look forward to using it tomorrow. Thank you.
Thank you so much. Congratulations on your successes and the outcomes that you've contributed to. My Swahili will only go as far as saying asante sana. So we appreciate your time and sharing your stories with our audience. Bahman, thank you so much for joining as a guest co-host.
Thank you, Laila. Thank you.
And to the audience, we hope you enjoyed this episode and will continue to visit us at Forecasting Impact Podcast. Thank you all.
Thank you.
Thank you.
Thank you for taking your time and listening to Forecasting Impact. If you liked this show, please subscribe to our podcast and leave a review. We appreciate you, and we look forward to seeing you at our next episode.